All right, let's get started. Hi, everyone. Thank you so much for joining us today for today's roundtable as we prepare for the release of the Supreme Court decision in Dobbs versus Jackson Women's Health. I'm Kelsey Rhodes. I use she, her pronouns, and I'm the interim director of Voice and Communications at Physicians for Reproductive Health. Since the draft decision leak, Physicians for Reproductive Health and Abortion Care Network have been working tirelessly to connect abortion providers and clinic staff with reporters to share the impact of abortion bans on the care that they provide every single day and how they're preparing for the inevitable changes in care provision in the coming weeks. Throughout this entire time, they've continued to care for patients day in and day out, and it can be challenging to find time to take reporter calls in the midst of navigating patient care. This triggered the need for today's call to find a time where providers and clinic staff workers across the country could share with you what they wish the rest of the country knew about abortion care in this moment, and the narratives that they wish they saw lifted up in the media. Through all of this collective grief, discomfort, and all the unknowns, abortion workers across the country are continuing to lead with deep care for their communities. Before we kick off to the panelists, I want to give a huge shout out to my co-conspirator for this call, Jay Thibodeau, Abortion Care Network's communications director, who I'm grateful to collaborate with every day, and the wonderful team at Berlin Rosen who helped make this happen. The format of this call is as follows. You'll hear from each speaker for 5 minutes, and then we'll open it up to questions. We'll only be taking questions submitted in the chat. And if we aren't able to make it to all of them in the time that we have, we'll document your questions and one of our panelists will follow up with you. And with that, we'll get started. It's my pleasure to turn it over to Dr. Jamila Parrott. Dr. Parrott is an OBGYN and abortion provider in Washington, D.C., and is the president and CEO of Physicians for Reproductive Health.
Thank you so much, Kelsey, for that introduction. And thank you all for taking time to join us. I know your schedules are busy. We're deeply grateful for your partnership, but mostly, for your commitment to ensuring accurate information about comprehensive reproductive health care, including abortion, especially in this moment. For those of you I have not met yet or haven't worked with before, as Kelsey said, my name is Dr. Parrott. I use she, her pronouns. I'm an OBGYN and an abortion provider in DC. And as you heard, the president and CEO of Physicians for Reproductive Health. PRH is a network of more than 440 doctors and supporters dedicated to protecting the rights of all people to access safe, affordable, comprehensive reproductive health care. We use science, medical expertise, and our lived experience to shape the public discourse by mobilizing the medical community, training, educating, and organizing providers. And it's because we understand how critical it is that we use our voices to shape policy, practice, and legislation, knowing that those things often impact and sometimes dictate the care we can provide in our own communities. Our goal, our purpose, our belief is that every person should have the right to the reproductive health care they need, and that care should be grounded in agency, autonomy, dignity, and respect. We're all gathered here this afternoon because we are at a dire moment for access to abortion in our country. And while this moment is critical, the reality is that abortion access has been non-existent or exceedingly difficult to obtain for many of the people we care for quite some time. Stigma, shame, harassment, political interference, all have conspired to ensure that this time-sensitive, essential care is pushed out of reach for our communities. And while the final SCOTUS decision has not been made, it seems evident that the majority of the justices on the Supreme Court intend to take away the constitutional right to abortion. And this is exactly what we feared would happen as we watch states across the country ban and restrict abortion access, and as the Trump administration stacked the courts with extreme anti-abortion judges. This was their plan. It's more evident now than ever that the claims that anti-abortion politicians have continuously made that bans are intended to improve the health and well-being of our families and our communities is blatantly false. As a network of providers, we're reeling, experiencing shock and disappointment. But at the forefront of our minds are the people and the communities we care for. We have to center the people who have abortions, people who provide abortion care, and those who make access possible today and in the days to come. This moment matters. Our patients matter, our communities matter, and the language, the context, the stories we share when talking about abortion, it also matters. I don't have a lot of time, but I want to spend just a few moments talking about language, because for decades we rallied around the narrative of choice to describe the need to access abortion care and those who support it. As a doctor and an abortion provider, I'll tell you clearly, I have never met one single person who was seeking an abortion that felt like they had a real choice. The truth is that choices are not equal. They're not judged equally. They're not experienced equally. And many of the choices our communities face are so narrowly focused that they aren't really a choice at all. The reproductive options that pregnant people face is shaped by the resources they have or do not have. Having or not having access to proper resources, including family and social support, fundamentally shapes the meaning of choice. When systemic inequity is our platform, focusing our language exclusively on choice is disrespectful, and it disregards the lived experiences of the people I and my colleagues care for. So we shouldn't be talking about choice or writing about choice. We should be talking about agency. We should be talking about autonomy. We should be talking about justice. That is what we seek, and that is not a choice. It's a human right. We should always be speaking about the right to decide if, when, or how to build our families as a human right. Secondly, I want to mention that our communities and our network of providers still need you all in this moment to commit to telling a more complicated story. There's a desire to reduce the experiences of abortion providers and those seeking care down to sound bites and retweets. The reasons that people need abortion care is as varied as the people who need it. There is no single story, and the desire to tell abortion stories that are only filled with grief or trauma and sadness is not only factually incorrect, it's harmful. It contributes to stigma, it contributes to shame. The reality is that abortion and contraception and pregnancy, they happen like everything else within the context of each individual's life. They're shaped by the social, political, and historical context in which we as providers do this work. One doesn't have to be pregnant or planning a pregnancy for these issues to matter to you. This is not about the capacity for pregnancy, but about our right to control our bodies and our health. This includes the right to survive our pregnancies, the right to parent our children, as well as our right not to be pregnant at all. The reality is that those with increasingly limited access to abortion care are the same communities who are most heavily impacted by state violence, by inequitable maternity, and morbidity and mortality. It's not coincidental. It's the result of centuries of institutional and structural inequity and racism in our health systems and structures. Advancing access to abortion care must be understood within this context as well, and that requires us to prioritize access for those at the margins of care. These are not distinct or separate issues. The fights are not separate in the lives of our patients, and so they can't be in our work or the way that you are writing about these issues. And finally, I can't express enough that regardless of what the Supreme Court decides, people will continue to need care. I want to be clear when I say that there is no debate when it comes to healthcare. There is no other side to science, to evidence, or to medicine. It's not political. It's not theoretical. Politics has no place in the decisions that private citizens make about their bodily autonomy, our lives, and our futures. The consistent desire to tell a balanced story or to present both sides of the issue in media outlets results in the perpetuation of stigma and misinformation. Leading medical organizations like ACOG have discounted the opinions and perspectives and theories of organizations like the American Pro-Life OBGYNs or APLOG. We need you all to stop repeating their lies and dressing it up as facts. It causes harm. I think I'll end my time here and turn it back over to Kelsey. But thank you all for listening, and I look forward to your questions.
Thank you so much, Dr. Parrott. I'm now pleased to introduce Mercedes Sanchez, Director of Communications at Cedar River Clinics in Washington.
Hello, everyone. Thank you to the journalists for being here, and thank you to my fellow panelists for everything you do. Cedar River Clinics is our reproductive healthcare clinics in Washington State, and we provide first and second trimester abortions. We were founded in 1979, and as a second trimester provider, we've already been serving patients from out of states for over 4 decades because of restrictive laws. No matter the SCOTUS decision, abortion will remain legal in Washington, and Cedar River Clinics is committed to providing abortions to Washingtonians and those who need to escape oppressive state laws to receive health care. The SCOTUS decision will not be a surprise, but it will still be devastating. We started planning for this in 2017 and then expedited our plans because of COVID. We launched our telemedicine program, we streamlined our processes, and we expanded our collaborations, clinical, legislative, and with abortion funds. We are very aware that Washington and other states where abortion is legally protected are being seen as the safety net. And honestly, the safety net has holes in it. Many independent clinics like ours are still recovering from COVID, and there has never really been significant resources available to abortion clinics. Right now, our focus is on seeking funding and hiring additional staff to handle the surge of patients. We're also doing our best to prepare for the unexpected. We may be buried in legal actions, both civil and from the hostile states themselves. These lawsuits may result in financial burdens that could force clinics to close, which I have no doubt is the intended strategy. These lawsuits bring another concern, as well as the widespread news of clinics in states that have legal protection, which is security. We expect a significant rise in harassment of clinics and providers, which always includes the risk of violence. But most concerning to us is the danger to patients. Soon after the trigger laws go into effect, there will be many dangerous impacts that will cause negative health outcomes and fatalities. For example, emergency care for patients suffering ectopic pregnancies and miscarriages that can result in ruptures, infections, sepsis, and death if they are unable to get emergency medical care in their own state. Here in Washington, we have many religiously affiliated hospitals, and a common directive is to not treat a pregnant patient if there is a fetal heartbeat. This has resulted in patients being denied care and transferred to Cedar River clinics and other providers. Transfers to clinics will not be an option in states where abortion is illegal, and there will be no possibility of transferring out of state in a timely, life-saving manner. This nightmare scenario is only going to get worse as time goes on. Abortion bans and clinic closures will affect families for generations. Studies have shown that when people do not receive a wanted abortion, their families are trapped in poverty for years and often experience a lack of basic needs, including housing and food. The wealthy, including the justices, anti-abortion politicians, and their families, will always be able to travel for abortions and not face financial devastation. It is immoral and unethical that these same politicians do not support social service programs when there are children in need. This isn't just about abortion. It is a human rights issue that will impact millions. People often ask us how they can help. One thing you can do if you're able is donate money to support abortion access. You can donate to abortion funds, and please donate directly to independent clinics like Cedar River Clinics. Patients need well-resourced clinics to travel to. Independent clinics provide 3 out of 5 abortions in this country, and that number will rise. We need help to prepare for the influx of patients. Perhaps even most important, please vote this November. It appears our rights are only as safe as the last election. In Washington state, 87% of our legislators are up for re-election, which means it's entirely possible Democrats could lose the majority in the state House and/or Senate. complacency is dangerous in states that have legal protections for abortion. Please vote for candidates who are not afraid to say and wholeheartedly support abortion. All the studies and polls show that the majority of Americans support abortion, yet here we are. People from all political parties need to vote to protest this dangerous and regressive Supreme Court decision. Vote to show our numbers and how much power we hold in this country. And if you feel particularly inspired or enraged, please run for office. We need better representation. The end of Roe versus Wade is not the end of abortion. Roe v. Wade was never enough. Many people from marginalized communities, including low-income, rural, and BIPOC communities, have never had meaningful access to abortion. We need to go beyond more and do more than simply reacting to the current situation. I hope the SCOTUS decision causes an unstoppable wave of change and creation, one that upends our political system. We need to think bigger, better, different. A whole new reality of healthcare, bodily autonomy, freedom, and true diversity and representation in our national and state governments. Thank you.
Thank you, Mercedes. Next, we'll hear from Katie Quinones, the Executive Director of Women's Health Center of West Virginia.
Hello, and thank you for being here. Abortion bans like the one we are facing in the Dobbs v. Jackson Women's Health Organization case will cause broad and unrelenting harms beyond whether or not a person can get an abortion. This decision will harm every single facet of a person's life who is seeking an abortion, but lives in one of the 20+ states that will ban it, like my home state of West Virginia. Nearly 16% of West Virginians live below the poverty line. The national average is 11%. In fact, West Virginia ranks 49th in the nation when it comes to women living in poverty at 23%. People who can't get an abortion face economic hardship, which lasts for years. Being denied an abortion lowers a person's credit score and increases their amount of debt and likelihood of eviction or bankruptcy. The consequences of being denied an abortion do not only impact parents. The effects are felt throughout the entire family, including children. People who can't get an abortion are more likely to stay in contact with a violent partner, so the cycle of abuse continues. They are more likely to raise the children they have as single parents. These factors all combine to create worse childhood development and wellness outcomes for children. Here in my home state of West Virginia, we have one of the nation's highest rates of children living in foster care, and we rank 45th in the nation for teen births. For the West Virginians who are able to scrape together the resources, they will travel hundreds to thousands of miles out of state to access the abortion care that they need. And this will force them to spend hundreds, sometimes thousands of dollars on travel costs like gas or airfare, lodging costs, and childcare costs. They will do all of this while missing work and the wages that come along with that. I know firsthand how crucial abortion access is. When I was a senior in high school, I had my first abortion. I did not want to be a parent then. I wanted to go to college at Marshall University and pursue a journalism degree. I saved up to $350 for the procedure by working at my after-school job at a local pizzeria and arcade. I hid my pregnancy for 2 months while I worked to save the cash for my abortion. I didn't have a driver's license or a car, and I lived over an hour away from the nearest clinic in my state. I imagine how my story would have ended had I been a teenager living in a world without Roe v. Wade. Would I have been able to get out of state for care? Would I have finished high school? Would I have earned my journalism degree? Would I be chained to the abusive and controlling older man who got me pregnant? Would I be here speaking with any of you today? My story is not unique, and stories like mine will continue to happen. But now those West Virginia teens will have to navigate insurmountable obstacles to get the abortions that they need. So how will the Dobbs case affect my state of West Virginia? In short, it will push more and more West Virginians into poverty. It will multiply the number of children who enter our state's already overburdened foster care system. It will drive up our teen birth rate. It will force people to remain pregnant against their will. It will create greater health disparities between those with privilege and those who are marginalized. Make no mistake, dismantling abortion rights is an attack on West Virginia parents, domestic violence survivors, children, working class families, and so many more. I've given you statistics, I've shared with you my own story, and I've told you what I think the impacts will be, but I want to tell you why all of this matters. It matters because we should all be able to pursue our educational and career dreams, and everyone should be able to create the families that they dream of. Everyone should be able to get compassionate, expert care that they can trust in the communities in which they live. Roe has never been enough, but in states like mine, it is the only thing that is protecting abortion access. Thank you.
Thank you, Katie, and thank you for sharing your story with us. We'll now hear from Tammy Kromenacher, owner and clinic director of Red River Women's Clinic, the only abortion clinic in North Dakota.
Thank you. It's hard to follow. Like she said, I'm Tammy Kromenacher. I use she, her pronouns, and I'm in Fargo, North Dakota. We've been providing abortion care in our community for nearly 24 years. We have been the sole abortion clinic in our state since 2001. We provide abortion care to pregnant people from North Dakota, parts of South Dakota, and northwestern Minnesota. We serve a huge geographic area, and many of our patients travel upwards of 4 to 6 hours just one way to receive care at our clinic. We provide approximately 1,200 abortions a year to a wide variety of patients, including a large proportion of Black and Indigenous patients. We offer both medication and in-clinic suction abortions 1 day a week with physicians who travel in from out of state. North Dakota is one of the most hostile states when it comes to abortion restrictions and regulations. We fought numerous battles with our state legislature, including being the first state to pass a 6-week abortion ban in 2013. And we have been in near continuous litigation with the state for over a decade on a variety of targeted restrictions of abortion provision. North Dakota voters were presented with the so-called personhood ballot measure in 2014 and resoundingly defeated this total ban on abortion by a clear margin of 64%. We know the vast majority of North Dakotans, as well as most Americans, support the right to abortion. North Dakota passed a trigger ban in 2007. The ban calls for abortion to be outlawed in our state within 30 days if Roe is overturned in whole or in part. If our worst fears are realized and the Supreme Court does overturn Roe, we'll be forced to close our doors within those 30 days. If the court upholds Roe but bans abortion after 15 weeks, that could be construed to be an in-part overturning of Roe, and the North Dakota Attorney General could declare that the trigger ban goes into effect. There may be paths forward with litigation, but there are no guarantee those efforts will be successful. So like many providers in our field, we've been exploring contingency plans. We are located just 5 minutes away across the Red River from the state of Minnesota. Minnesota is considered politically protected for abortion access. We are working on a plan to open a new facility across the river in Moorhead, Minnesota, if we are forced to cease offering abortions in North Dakota. We know the challenges our patients face with travel distances, time off of work, and sometimes literally even winter weather closing down every road in our state. We want access to abortion in our region to essentially remain the same for them. Independent abortion clinics are savvy, flexible, and resilient. If Roe is overturned, we plan to diligently and tirelessly continue to provide abortions as long as we legally can in North Dakota, while simultaneously gearing up the space in Minnesota. Our goal is to have little to no disruption in services. Currently, clinics providing abortion in Minnesota already have a 3 to 4 week wait time due to demand and staffing issues. This will only worsen if Roe is overturned and a surge of patients look to Minnesota for their care. It may sound like a simple solution, just open up across the river, but it's not. It won't be easy. Opening a new facility takes an enormous outpouring of resources. Like most indies, we don't have vast amounts of people power or different departments handling all the demands placed upon us. We are already stretched to the limit. All the usual aspects, such as utility changes, figuring out how the snow will be removed, moving medical equipment, and installing a new security system will be involved, but so too will be registering with the state, learning the ins and outs of existing laws in another state, forging new relationships with those we have to interact with in order to provide abortion care in that new state. I could go on and on. Clinics and patients should not have to face such challenges. Independent clinics are called on to constantly adapt, innovate, and bend over backwards to stay open. This cannot be the solution to the current and impending abortion access crisis. I had a young patient from Western North Dakota tell me this last week how scared she was about the Supreme Court's upcoming ruling and what it will mean for herself and her friends going forward. We don't want to leave North Dakota. We fought year after year to keep our clinic open. We've created connections and systems within our community to navigate all these rules and regulations. North Dakotans will be confronted with abortion being illegal in their state. They'll face a whole new set of fears, stigmas, possible confusion about where to even obtain an abortion. They might even wonder, can they even legally leave their state to have an abortion? It will be burdensome for both patients and the clinic to navigate these difficulties. If we're forced to abandon North Dakota, I will truly mourn. We haven't fought this long, and it's hard to give up, give in, and abandon this region. I'll do everything within my power to see that Red River Women's Clinic continues to provide abortion care. We will find a way to pull this off. We always have. We're here to stay because our patients deserve nothing less. Thank you.
Thank you so much, Tammy. And last but not least, we'll hear from Dr. April Lockley, family medicine physician in New York, fellow with Physicians for Reproductive Health, and medical director of the Miscarriage and Abortion Hotline.
Hi, everybody. Thank you for the remarks so far. Just want to take a deep breath. It's a lot. I appreciate the work that everyone is doing. And thank you for those who took the time to listen to us share about the realities of what we're dealing with. So thank you, Kelsey, for the intro. So for those that don't know, the Miscarriage and Abortion Hotline is a hotline that was founded in 2019 by 2 primary care clinicians. We're a group of volunteer physicians who answer and provide medical support to people who are self-managing their abortions. And so the hotline was founded because the founders knew that communities had been taking care of themselves for really hundreds of years, and that people were self-managing their abortions. But as access was worsening, especially after the Trump administration, there were more and more concerns that people would be seeking unnecessary medical care from hospitals and being criminalized. And so the hospital was founded to help people essentially stay out of the hospital if they didn't need to be there when they were self-managing their abortions. And so it started with about 11 primary care physicians covering about 12 hours per day. In the beginning, we only maybe got 1 to 2 calls per day, but the volume has really continued to grow. Since then, we saw a significant bump during the height of the COVID pandemic when people couldn't access care. And then after SB 8 was enacted, people self-identifying that they were calling us from Texas. And so at this point right now, we have 50 volunteer clinicians. That includes doctors, midwives, nurse practitioners, and physician assistants. We cover 18 hours of the day from 8 a.m. to 2 a.m. EST. We talk to people both in English and Spanish, and we can take calls from anywhere, from people calling us from anywhere in the US or territories. And so our volume now is we get on average about 20 to 30 contacts per day from different people calling and texting us through our secure encrypted messaging platform. And so why are people calling us? So one, I just want to clarify that we never ask for any kind of identifying information. We are not like collecting research. And so we really have no precise data about who exactly is calling us, how old they are, really any specific information. But we have obviously noticed some themes over the past 2.5 years about who calls us. And so most people call us, one, to find out where they can access pills or how to get pills. Then they call us wondering about how to take the pills and clarifying instructions of how to take pills. Then people ask us questions about side effects they're having and the bleeding that they're having. And then other people call us because they're worried that the process might not have worked. And then lastly, there's a small group of people that call us wondering if they can take pills after about 11 or 12 weeks of pregnancy. And we follow the WHO guidelines for how people can use pills safely and effectively after 12 weeks of pregnancy and how they're able to self-manage in those instances as well. So pretty much about 99% of the time, people are able to, we're able to provide support and reassurance to people that the process is going well and safe, and we're just another support instance for them. And so really from the standpoint of being a clinician on the hotline, it's really just reinforce my understanding that people and communities can take care of themselves and that the abortion process can be safe to manage at home. And so it's very difficult to hear people's stories when they do share with us that people sometimes would prefer in-person care, but logistically they're not able to get to in-person care. And so they feel that pills are their only option. So it's a good reminder to me that while self-managing abortion is typically very safe and effective, it really shouldn't be the only option that people have. And people should be free of stigma and criminalization, no matter what method of abortion that they choose. Other people are very grateful to learn that they can order pills and thankful that we provide the information that they can order pills, and that they really give us really good feedback that they're very thankful for our resource. And so kind of where does that lead us when we're talking about as access is worsening? So like I mentioned, self-managing is an option. It is safe and effective, but it really should not be the only option. And in order to self-manage in this day and age, you really have to be computer savvy, able to navigate how to get pills online or know a community that has access to pills. And then if you're buying pills online, you need to have a debit or credit card or prepaid card, and then a secure place to accept mail. Obviously, not everyone has that. And then also language barriers are often a concern of mine. I've noticed that people who call us who speak Spanish, they're the ones that often call us multiple times. It's because they need a lot of clarification as they're trying to navigate the process of getting pills and taking them safely. And so really, I've just been grappling with what do we do to get this information about self-managing into the communities in a patient-centered, language and culturally appropriate manner. And we know that communities, often take care of themselves, but with the increasing threat of these legal repercussions of pregnancy outcomes, it's even more essential that people have this accurate information about how to safely take care of themselves. And I just wanted to point out one more thing that other panelists have mentioned, really, how is this going to affect all aspects of sexual and reproductive healthcare? As many people have already mentioned, those that are going to be the most burdened with legal repercussions are those who already face bias and discrimination when seeking healthcare. People that are Black, Hispanic, teenagers, young people, the disabled, LGBTQ persons. Those are the people that are going to continue to face the most barriers and discrimination. And there's a lot of talk about how these abortion restrictions are going to affect miscarriage care, ectopic management, IVF, and really all aspects of sexual and reproductive health care. And people have already been jailed for their pregnancy outcomes, so this is likely going to get worse. There are some bold clinicians out there who really will do anything for their patients, but most of us work within systems of oppression that don't really allow us to take care of patients how we would want to, due to institutional restrictions and obviously legal restrictions. And so clinicians, as we move forward, we really should be comfortable providing follow-up care for patients who self-manage if they have questions or concerns, as well as clinics being comfortable providing that follow-up care as needed. And so it definitely is a lot of what seems like doom and gloom, but as we grapple with all these changes, really for me, being a physician on the hotline has reinforced my understanding that people can and should be able to take care of themselves in the manner that they see best for their circumstances, and that using pills outside of the formal medical system is safe and effective. We just need to continue to work towards spreading this information in an effective manner to as many communities as possible.
Thank you so much, Dr. Lockley, and thank you again for everyone sharing your remarks. We are now going to transition to the Q&A portion. As I mentioned at the start of the call, and maybe some of you joined us a little late, but procedurally what we'll do is if you could type your questions either using the Q&A function at the bottom of your Zoom screen or in the chat, We'll make sure to get to your question either on the call or after the fact. So our first question, this